just to say that we're very happy if anyone's observing the meeting and thinks that they would like to ask a question. If you put in the chat box, when we get to the end of the meeting, I will make sure that there's an opportunity for us to review your questions and to answer them best we can before we close the meeting. So with that, we go without further ado to our first substantive item, which is the Chief Executive's update. So over to you, Angie.
Thanks, Helen, and morning, everyone. Just spotting the comments in the chat box. Look forward to the day too that I can actually say hello in person to everyone. Thank you for all the feedback last week. It was very strange talking to you all in the studio facing a screen, and at least I can see a few faces today, so nice to see those. I can see. And Denise, yes, if anyone has got their mic on, can you turn it off, because we do get a bit of feedback. So I'm going to start by apologising really for a very much a COVID focus. I'd hoped today, even last week, preparing the agenda, that we'd be able to talk more widely, but unfortunately, as you'll all be very aware, that COVID is dominating our lives very much again, not that it's ever gone away. So I thought I'd give you an update on where we're at as of today, both locally and a few highlights from our regional call yesterday, and then not preempting Tony's substantive item later. Lots of work around restoration and recovery and how we're managing that in a COVID world and planning for winter. So in terms of today, we've 4 inpatients who are COVID positive, 2 of those in ITU. We did have a few weeks where we had no patients. We're not seeing the rapid increase that some parts of the country are in terms of hospital admissions yet, but clearly if measures aren't taken, as Boris announced to us all yesterday, we can see that growing presence in the community. Again, Derbyshire isn't as high as some areas across the country, but concerning that all of us are seeing that increase. We had an update from region yesterday, so this is the whole of East and West Midlands, but we are seeing an increase particularly in the 20 to 29 and 30 to 39-year-old age group. Our position in the over 65s is at the moment pretty static, which is different, for example, to the Northwest, where they're seeing an increase across all areas. But clearly, as I said, if we don't maintain all the measures we need to, that increase will translate into those who are more vulnerable, and we don't want that as far as possible. In terms of the plans in place to manage that increase, nationally, we're in a good position for PPE, drugs and ventilators. So those critical areas that we struggled with in the first surge of outbreak, we're in a much better place than we were previously. And the way we're managing across our local patch and regionally and nationally is managing outbreaks at the moment. So how we focus in on where there are outbreaks, we've learned a lot over the last few months. So whether that's in a care home, in a hospital, or in schools, and it's care homes and schools amongst staff, in particular in care homes, not necessarily patients, that we're seeing those outbreaks. And there's around 120 of those across the whole of the Midlands region at the moment that are being managed. I always hang on to my desk when I say this, because touch wood, none for us in our hospital. Obviously there are care homes where some of those outbreaks are being managed, but a big thank you to all our teams for the huge work and effort that they put in to make sure that we're not seeing those outbreaks within our organisation at the moment. You'll also be aware that testing nationally has presented a few challenges for us. I say it slightly tongue-in-cheek. I can't see Tony's face, but it's his favourite subject. I have to say he's done a sterling job from his regional director role in supporting the prompt action when we picked up that there was issues with testing, and we're not alone in terms of demand outstripping supply, but some good local support to make sure we continue to prioritise getting our patients tested and our staff where we need to get them back to work. But I'm sure Tony will pick up any more detailed questions you have on testing. And likewise, Tony, we'll come back to how we're managing restoring our elective services. I think Helen will give us an update on the system. There's lots of activity happening around where we're at as a system and our journey onto an integrated care system, and lots of learning that we've done and are still doing around COVID and what it's meant for us working as a system. And last week we received our financial allocation, which for the first time has come to the whole system rather than individual organisations. And again, Lee, I'm sure as far as he's got working with his fellow DOFs, will be able to give you some headlines around what that's saying for us in Derbyshire. Just a couple of other areas I wanted to highlight. Our flu campaign has started, so our practices started delivering flu for our patients' weekend clinics on Saturday, and our staff vaccination programme started this week. A good initial response, and we always set ourselves that high standard that we do well with flu vaccination, so I'm sure and hoping that we'll do the same again this year. We've also been working closely with our mental health partners. We're seeing an increase in mental health presentations based amongst our patients presenting at A&E, and challenges for all our staff, and I think that energy that we all need to see us through the winter is going to be a constant reflection for us all on how we make sure we're looking after each other and support ourselves. And I'm really pleased to say that we've had some recognition, quite rightly, around all the work that we've done for supporting our staff, mental health and mental health wellbeing support that's in place. And some really positive examples, not getting it right all the time, but again, how we've supported staff, whether they've been shielding or coming back to work. We've been doing some listening events this week, and I was really pleased to have a member of staff come to me yesterday. I was all psyched up to listen to their challenges, and she just wanted to say thank you of how well she's been supported through such difficult times, and she was very poorly with COVID. So really heartening to hear. But not to be complacent. You'll be aware that the people plan has been published. So if you're joining us at board next week, then Zoe and Jeremy will be giving the highlights on where we're at with the people plan. And I feel very assured that we've done lots of work so far, and proud of what we have done. I say, notwithstanding that there's lots of work to do to look after our people in the coming months. So I'll pause there, happy to take any questions or comments, or Helen, if you want to just follow on with some of that system work before I do.
Briefly add on the system work that we've as chairs interviewed for a joined up care Derbyshire system lead in anticipation of us becoming an ICS. So that recommendation needed to be put forward to NHSI. We learned yesterday that has been approved. I haven't seen any announcement on the wires yet, so I won't share with you who that is, but you can expect an announcement very shortly, and I think you'll be pleased that we've got somebody at the helm there. We'll be submitting our application to become an ICS by the end of this month, and we anticipate being in shadow form from the 1st of November as an ICS. The kind of drop dead date for being an ICS is not until next March, so we felt it was very sensible to be kind of up and running in shadow form to give us, you know, a good period to establish new ways of working. So that is all progressing apace and taking a lot of work, as indeed has the system level work around the phase 3 submission about how it is work is going to be restored and recovered, and we're just about to come on to an item a bit later on the agenda about that, so I don't want to go into any of the substance of that, but just to say there's taken a huge amount of work across the system, with Angie leading the elective element of that, and I don't think you could have put any more into getting a proper system perspective on all of that. So a big thank you to you, Angie, and to your colleagues for everything that you've done in that regard. And last but by no means least, there's an increased focus now in anticipation of becoming an ICS in shadow form as early as November, of getting more NEDs and governors involved in the governance arrangements of the new ICS. So we've already brought together some NEDs that are looking at digital across the system, and Keith is leading the charge in that regard. In fact, I might ask Keith to say a few words about that. And similarly, we've got a focus on finance and performance, with the chairs of finance and performance committees of providers coming together now in a system way. Hal and I did reflect in a discussion yesterday, as indeed did Jane and I, that it will be good when we get a similar arrangement in place around quality, because obviously there's an awful lot we can do together as a system in that regard, but I anticipate that following on very shortly. So I think I'll pause there. If we've got, I can't see you, but if we've got either Jeremy or Alison on the call, it would be very helpful if you wouldn't mind giving a vignette of how things are at system level working in respect of your committee's work.
Hi Helen, I'm more than happy to give some commentary on the Finance and Performance Committee. So we've pulled together representatives from each organisation, primarily the chair of Finance and Performance NEDs and all of the directors of finance. And we've met, I think, now 4 times. And the initial stages were around agreeing terms of reference and what we would be looking at. But most recently, it's been around making recommendations to the Joined Up Care Derbyshire Board about financial controls and how financial decisions will be made. And I believe that there's a board meeting with Joined Up Care Derbyshire on the 15th of October that will be looking at some proposals about management of different types of resources, from financial envelope for management of all the services, but things like capital as well. So that's where we are at the moment. So still forming really, rather than all the processes and decision-making authorities completely in place and practiced. So still developing.
Very good, really helpful first-hand account. Thanks, Alison. Keith, are you on the call?
Yes, Helen. Hi, good morning, everyone. So from a digital perspective, we have a Joined Up Care Derbyshire digital stream, which Tracy Allen from the CEO of the Community Trust chairs. I now sit on that as a non-exec, and we have a very specific task and finish project at the moment around a shared care record for all of Derbyshire, which I made reference to in my digital section of the next element. But I chair that. We now also have a non-exec from Derby and Burton on that, and we have a non-exec from the Community Trust sitting on that task and finish group now, with a group of around 20 or probably about 25 execs from all across the 4 big providers as well as primary care. So really good joined up working. I think it's still hard in places, but actually people seem to be very focused on looking at it from a global perspective of Derbyshire, and less about their own trust and more about trying to deliver it for the wider community. So I would say early days yet, Helen, but we're making good progress and really positive.
Very good, thank you very much. Angie, we've got a question on the chat from Judy about planning clinically and ensuring sufficient resources for looking after people with long-term impacts of COVID.
Yeah, it's a really good question, Judith, and it just reminded me of a conversation I was having with a member of staff yesterday who had been very poorly with COVID, and was saying, I'm not sure now what are my underlying health conditions and what are COVID. I know the support in place through our outreach team for those patients that have been particularly poorly that we support, but I'm not sure we've necessarily picked up that longer term as a system. So it's a good point I'll take back. I don't know whether Hal wants to come in terms of the impact that we're seeing and maybe how we could do that as a system a little bit more.
Hello everyone, it's Hal here. Just to add on that, Andrew referred to the outreach team, which is for patients who've actually been in the critical care areas of the hospital, and there's a very kind of set way that they're all followed up once they leave hospital, as we do for other critical care patients. We're also doing very structured follow-up from a respiratory point of view. So there was uncertainty at the beginning regarding, what imaging follow-up these patients might have, and whether there was a risk of them getting long-term fibrosis or long-term lung scarring as a complication of coronavirus. So that's been taken on by my respiratory consultant colleagues, working alongside Anoop and the radiologists, so that we've got a set an agreed protocol, if you'd like, for how we follow these people up and what imaging they get, and they're all being contacted regarding ongoing respiratory symptoms. Patients that have less clear-cut symptoms, so I'm thinking about, for example, you'll have all heard about patients with loss of sense of smell and taste and things. I have to confess, I don't think we've got a clear way of following those up, because such things like that would normally be picked up in primary care rather than it being a hospital thing. And if necessary, then, for example, with that, then primary care might refer into our ENT services. The bit about general psychological well-being and sort of community follow-up about the sort of more general after effects of coronavirus is something that's being picked up in the community. I know the Derbyshire STP is doing some work on that, and how we will support people in the community, particularly regarding mental health and psychological aspects. But it's being the focus of that is in the community rather than in the hospital, as you might expect. But it is happening.
Very good. That's
helps
very
answer.
helpful. It does indeed. Very helpful to have a flavour of all of that. Thank you, Hal, and thank you for your report, Angie. Just going to check that before I move on, that there are no further questions. Just a remark from Luke about the shared care record working well, and long overdue, but a brilliant prize. I'm very glad that Keith is responsible for the stewardship of that on our behalf across the system. So thanks also to Keith and Alison for your updates. I'm going to move us on to the next agenda item, which are the Governor's measures of success. This is the central exhibit at any meeting where we're having the full progress report, which we are today. It's an opportunity, as I always remind you, that if you have any other questions about performance, feel free to raise them in the context of this report, and we're going to give it plenty of time to do it justice and just step through it. And we've introduced a new item, as you'll expect, about restoration and recovery, and Alison's leading the charge on that. So Alison, if you'd like to kick off, please.
Thanks, Helen. So this is the first time that we've included restoration and recovery in the Governor Measures of Success, and it is slightly strange coming between Angie's Chief Executive report and Tony's full report on restoration and recovery. So I'm not going to go through the report word for word, but what I've tried to do with Tony's help is describe some of the management processes and some of the assurance processes that are in place to know that things are being planned and executed in the right way. You'll notice that my update is short on numbers. That is deliberate because we're in such a changing environment, and I'm sure Tony, during his restoration and recovery paper, will give you lots more numbers than I can. But it is at the moment about being fleet of foot, very planned and deliberate in what we're doing, but taking into account the ever-changing situation with COVID and government advice. So I'll probably leave it there, Helen, and just take any questions, because it's really demonstrating the amount of grip and control we have, which from assurance point of view, I'm very happy, but also being, as well as being structured, being able to respond in the right way to change in advice, which seems to be moving every few days at the moment.
I think that's pitched perfectly, Alison. As you say, you're sandwiched between two R&R updates. But I think it's important that Council of Governors hear that we as NEDs have oversight of the R&R phase 3 submission, and indeed on an ongoing basis in the trust. So we've got that from you, Alison, which is good. I suggest that we don't take any questions now, because we could take questions of you and Tony at the next item, because the performance may well go hand in hand with the assurance and the oversight. So we'll do that then. But thank you for leading off. If I could turn to Jane next, please, and we're going to talk about patient care, please.
Good morning, everybody. So you've got a report in front of you, and the information is based on 2 QAC meetings, which I just want to say were really, really positive meetings. Firstly, I want to just talk about assurance. So we've stated that significance assurance is maintained, and we have amended one of the BAF risk ratings with the approval of the board. So that was on patient experience, and that's in the light of some great progress that's been made by the emergency department in terms of friends and family test, etc. If I move on, I want to just pick up governance and management. So we're just doing a little bit of housekeeping. It's very timely in that we're having a new chief nurse in post as well, with some responsibility for quality assurance, but also whilst Sarah is also working at the helm as well. So we are taking that opportunity to look at our escalation processes. The Council of Governors will know that we've been working really hard on clinical effectiveness and looking at where things like the GIRF, the peer review programmes for quality of care are received, and also things like clinical audit. So that's a piece of work that was already underway, but QAC identified the need for it as well. Secondly, we want to look at our quality report. Like everything, it has really, really grown, and it is an absolutely massive report, and we just want to be really clear that we can see the wood for the trees. So we're taking again an opportunity to do a little housekeeping on that with the incoming chief nurse, and obviously working also with Hal. In terms of clinical effectiveness, we continue to have a bit of a focus on local and national audits and things like whether we have got any mortality outlier reviews. And I know that we've just recently received in the Trust the 360 internal audit report on clinical audit, so we'll be looking to measure our processes against that report as well. In terms of risk and performance, you'll see that there's a little bit of slippage on duty of candour, which we've previously really focused hard on and got it up to a really good level. And we do expect that to be recovered quite quickly. So I'm expecting the next report to see progress on that. Falls. We want to do a deep dive on falls. Now, this is not because we are specifically concerned about falls, but really because actually this has been a really good piece of work through the CQuIN, and having now funded the falls lead substantively, we actually want to see that that progress is maintained. And we know that she's doing some great work, and some of you will know through social media this week that it's Falls Prevention Week, and actually there are some great items going on appearing on Twitter from our staff, and some great engagement in that. So we actually want to kind of showcase that rather than deep dive it, if you understand my meaning. I really want to focus on the Infection Prevention and Control Board Assurance Framework, just to let you know that great progress again is being made on that. But really, really significant is that the review that the CQC inspector undertook of that work. And you'll see that our self-assessment has been reviewed, and we have been found to be both accurate and robust in that, and that is really pleasing. And actually for that to come from the CQC, that again is particularly positive. Clearly we can't move through the Quality Assurance Committee report and my report without talking about COVID. And my focus on this, and the committee's focus on this, has been particularly on patient safety and thinking about patient harms, and just making sure that we have the right review processes in place to be clear that if there is any untoward effects or impact from COVID, not only on the COVID patients but also on the rest of the patient cohort in the Trust, that our processes are able to pick that up. And I think that was well demonstrated at the last committee. We had a lovely presentation on Safe Care System, really, really good, useful live information, but again, committee really interested to see that we unlock the full potential of that, and that was a very good demonstration. In terms of learning and innovation, I just want to say as well, the committee receives regularly annual reports, and we received in the last 2 meetings, one on medicines optimisation and one on tissue viability. Both of these reports, whilst being very specific about the work that has been done, were absolutely fantastically well received. But I really want to say that they were a real demonstration of innovation and people owning their own area of work and leading and looking to take that area of work forward. So I think that that is really to be commended. I also just want to take this opportunity to say that yesterday with Sarah and Lee, I made a visit to the chaplaincy, and it was a really positive visit. And I think it's really important that we recognise the spiritual and pastoral work that's being carried out by Martin, particularly with Martin, and to say, you know, what a great inspiration, what a great demonstration of the trust values we saw yesterday. So really going to be important going through the winter when we look to support both patients and staff. And as usual, if anyone would like to join us at the Quality Assurance Committee just to observe, you can receive the Teams meeting via Liz Dean, so you'd be very welcome.
Thank you very much, Jane. Can I just pause there now, and if anybody'd like to ask a question, perhaps you could just be kind enough to put me please in the chat. That was obviously crystal clear, Jane. Well done, you.
Thank you.
In which case, I'm going to move through to Sue, please, and talk about our focus on improvement and innovation.
Thanks, Helen. Good morning, everyone. Bit of blowback on my microphone there. Okay. Again, as Alison said, I don't propose to read through the report in its entirety. I think that one of the things that I've been particularly delighted to see really in the last several months now, it's turned from few into several, hasn't it, is the ability of our teams to really drive changes through at quite some pace. And I think when we've talked about the LIA foundations and then our move to CUSA and all the amazing work being done by the Royal Academy, by Tony and Maria and team, that we've always talked about them as, you know, it's been a kind of a gradual program, really laying the foundations, building our capability and our competence to drive change. And I think what this past few months has been is kind of the proof is in the eating of the pudding, as they say. And I think the way that our teams have responded to the need to identify and then drive and implement and absorb change at the pace that they have is testament to the program and to leading the Chesterfield way and to the leadership that's been demonstrated. So I think that's the first thing I wanted to say really. You know, change can take a long time to develop a proper culture of continuous improvement, and I think that we have the work that's been done has stood us in very good stead for the challenging times we've had around COVID. When I was writing this, I think I used the phrase, whilst the immediate pressure for change has perhaps eased from a COVID perspective, and that's another little example of where, you know, the world changes on a sixpence, doesn't it, overnight? And so that might now not be true. And in my closing comments, one of the things I had said in the paper was, our challenge now is to maintain a healthy pace of change and to resist natural temptation to get back to normal. I'm reflecting on that and thinking that actually now, when we see what we face ahead of us in the next few months, probably the challenge for us is to make sure that we don't overburden our staff with any further change fatigue. I think the levels of fatigue will be high enough, and actually I think our challenge will be to just support our staff in getting through the few months of winter and absorbing the changes that are absolutely critical to our success. I think there's been some fantastic highlights that I've pulled out in the report, all of which I know we've talked about on previous board sessions and previous COGs, in fact. But some good highlights, I think, particularly our focus on the outpatient support. And as we've talked about in the past, when we used to talk about striving to deliver non-face-to-face outpatient supports, and our wild target of going from 4 to 9%, and the national target being 30% over 5 years. And of course, as people may well know, we got to 86% in 5 weeks, which is definitely something about needs must. And we're still at around the 50% mark. And of course, that continues. Given that the patient is at the heart of everything we do, of course, that the patient relationship and interaction during this next phase will, of course, be driven largely by patients, some of whom now will feel increasingly anxious about coming in, which might drive back up the non-face-to-face appointments. And I guess we will watch and see how that goes. But ongoing work to modernise the outpatients pathway, whether that's about the space that we use or the processes that we have. And we and Tony and the team are being instrumental now in the development of the new referral assessment system. And I think that's testament again to the team that we're at the forefront of that, being the pilot with a view to then rolling that out across the system. And I think particularly from my perspective is that was generated by one of our colleagues in the admin team. And again, that shows our ability as a hospital to really drive colleagues to identify improvement opportunities and then for us to bring them to fruition, which is, after all, what the Royal Academy has been all about. So I won't, as I say, labour any more of the points on the report, but I'm happy to take questions. And just thanks again to Tony and Maria and the team for doing a fabulous job, and all of the leaders in the Chesterfield indeed for driving through these changes in really tricksy times. Thank you.
Thank you very much, Sue. I'm just going to pause there now for a moment to see if anybody wants to come in on the back of anything Sue has said. No, well done, Sue, very clear. Keith, just to put you on notice with regard to RPC, I had a question from Margaret in the pre-meet about the adequacy of access to RPC on the back of an issue a constituent raised with Margaret. So in addition to covering the strategy piece, which I know you're going to cover, you might be just kind enough to give some general perspectives on how things are at the moment. Over to you, Keith.
Thank you, Helen. Yes, of course. I'll cover the main piece and then add that on at the end, if that's okay, I think. RPC, as you know, when we talk about RPC created a kind of vision and strategy about 3 years ago and the focus for them really was around operational recovery, operational capability and clinical capability to take RPC to a place where it could really focus and concentrate and deliver that care it needed to its local cohort of patients. And as you'll all be aware, I'm sure, has gone over the last 4 years from special measures from a CQC point of view now to good. And that has been actually a very rapid journey in primary care. And that's quite difficult to do in primary care and should be real credit to the team. But the work from RPC now over the last kind of 2 or 3 months has really been about creating a new vision and strategy for Royal Primary Care. So to take it from where we are now in 2020 right through to kind of 2025. So a 5-year strategy and vision for RPC and how it works with CRH, how it works with the wider Derbyshire and how it delivers that ongoing quality of care to its patient cohort. And that strategy is being worked on by RPC, Tony, myself with some support, Angie and others have all supported into that. And that strategy and vision comes to the board next week on Wednesday for review by the board. I think there's been a huge amount of work involved and it really does set, I think, a very clear vision for the opportunity for Royal Primary Care in terms of how it can work, how it can deliver better and more innovative care to its existing patients and how potentially it will allow RPC to potentially scale, but scale in a very collaborative way and work more collaboratively across certainly North Derbyshire and deliver its services innovatively and with real quality, but while also looking at how it really benefits from the support it gets from CRH and being part of the CRH family, if you like, and how that sits also now going forward with DSFS and the relationship of all of that. And that's set out very clearly in that document. So I'm not going to preempt that document, but a huge amount of work has gone into that. And as I say, it will be in the private section of the board on Wednesday next week for discussion by the board. And that hopefully will allow Peter and Joe and the team to then take that strategy forward and really bring it to life. So I don't want to underestimate the amount of work that's gone into that, because it's a really significant piece of work. Just to answer around current situation and access and how we manage in a COVID world, primary care obviously has been under significant pressure from COVID. Primary care is, in NHS England's terms, working to a non-face-to-face contact as the first point of contact. So most people will be being seen by the GP either, over video consultation or over the telephone. And then if they need to be brought in, they'll be brought into the practice face-to-face. That has been the challenge in access terms for all of primary care. And I think those of you will have been immune to some, won't have been immune to some of the press coverage in the last couple of weeks from NHS England and GPs pushing back about how hard they're trying to work in order to try and see their patients in the current climate. So I think it is a challenging time for access. I think RPC have responded very well to it. They now have their own RPC digital app, which is allowing better access for patients who want to come in digitally. And I think they've worked very hard operationally to try and make sure that their access is as good as it can be. But I think we have to be realistic in the current COVID environment that does present a significant challenge to primary care, because not all the normal routes of access are necessarily remaining open. And I'm sure that will be more significantly challenging over winter than it has been in the last couple of months. I think I'll close that, Helen, unless anyone would have any further questions.
Thank you, Keith. Ruth would like to come in. Ruth.
Yeah, just to reiterate, I think what Keith has said. Apologies if my puppy starts barking, by the way, he's just woken up. So yeah, we have worked very hard. We're looking at how we can get the appointment system sort of back up and running. Really, we've got some appointments that are available a few days in advance, some appointments available on the day. As Keith says, it is phone triage, but we are bringing people down if it's clinically needed, if it's going to change our clinical decision or if patients need that support. We're doing home visits. We're using the Red Home Visiting Service if patients have COVID type symptoms, obviously to try and keep everybody as safe as we can. Some patients are still a little reticent to come in because they're worried, but we do all we can to reassure them. So I think we're I don't know what the comment was. Apologies, I missed the pre-meet. I was actually in a meeting in the sort of Wednesday call for RPC, ironically. But yeah, we are working really hard, so I'm happy to answer any other questions if you're supporting Keith in that, if anyone's got questions about RPC and access.
Can I expand a little bit on the feedback I had from constituents?
Please do, yeah.
It was, there are two different instances really, one several months ago and one more recently. The access is, in some cases was still the telephones not being answered. Which is an issue. Also, Keith mentioned this new app where people can actually get through and get called back, which sounds great, except that patients don't actually know it exists, unfortunately. So somehow we've got to find a way of telling existing patients who could actually have used that, which both of my constituents that could possibly have done that, but they don't know it exists.
I think a text, it depends whether or not they've got a mobile number available, because I think a text went out to all patients. I've certainly seen it in many patient notes informing them about the app and how to download it, and I think there's also been a media strategy, but I can feed that back if people don't seem to know about it, and just see if it can be promoted again. It takes patients through a set of questions which filters out anything urgent. And then they're able to enter free text what it is that they need assistance with, and they are usually then popped onto a telephone slot to discuss that further with a clinician.
I mean, it sounds a really good system, but it's only as good as, and I suppose it goes back to a little bit of a comment that was made in the pre-meet about people who don't have access to technology. It's not going to be terribly helpful for, but at least if the people who do have the technology knew it existed, then that would be another avenue. So if we can find a way to,
we have had quite a few patients on the phone list which says, you know, booked through the app. So it is being increasingly used. So I'll feed that back now, Margaret. Thank you.
Margaret, we'll happily take that back, and as part of that, my day job in Chesterfield, I do this a lot, and patient adoption is really crucial in this, and it's not it takes time and effort. So we'll happily feed that back, and I think we'll look at how that features as part of what we're doing with rural primary care and how we might communicate that more directly, appreciating that it doesn't work for everyone, and you know, there are cohorts of people that this doesn't appeal to, so we need to make sure that both parties have adequate access as best as we can.
Thank you.
Very good, very good. Thank you very much, both Keith and Ruth, for those insights, and Margaret for raising the issue. Helpful that we can take that back into colleagues at RPC. So I'm going to move on now, if I may, please, to Jeremy, and we're going to talk about the whole of the people agenda.
Okay, thank you very much, Helen. Just the people committee timing seems to be out of sync with COG, because I find myself reporting here with the last people committee having been some time in the past, and we last met in July, which seems like a long time ago. Nevertheless, just a couple of things I wanted to highlight from the report in front of you. First is that we recommended to board, and board agreed that we should reduce the overall risk rating for this BAF risk from 12 to 8, but through a reduction in the risk likelihood, and that reflects our increasing assurance about the likelihood score. The second thing, which is perhaps more significant, is that the NHS People Plan has been published, as Angie referred to at the beginning of the meeting. There's a paper coming to the board next week about this, which will then come to People Committee in early October for further discussion. The overall People Plan chimes very well with our own people strategy, and in fact what we've observed is that many of the things that are being called for in the People Plan we're already getting on with. I think one particular thing to note is that the People Plan does very much place the overall system, the Joined Up Care Derbyshire in our case, the wider system, as being a very important part in the architecture of supporting and developing staff in the future. And to that end, a Joined Up Care Derbyshire People and Culture Board has been established, which met for the first time at the beginning of September. There was good representation from Chesterfield. I think I wasn't at that first meeting, but I believe it was largely getting established, getting to know you and so on. But that's very much going to be the focus for taking this agenda forward. The only other things to mention, obviously over the summer, there was a lot of emphasis within the organisation on trying to make sure that all staff got a break, because even if our politicians didn't recognise that we were going to be in for a stormy autumn and winter, I think everybody in the NHS knew it was pretty blooming obvious, not to put too fine a point on it. And my understanding is that that on the whole, most if not all staff have been able to get a break during the course of the summer months. And the other thing is that although the staff survey is only just starting to be rolled out, and we don't have any formal measure of staff well-being and morale, anecdotally, the reports are that staff well-being and morale has held up remarkably well, considering what an extraordinary period we've been going through. I'll leave it at that. If Zoe wants to add anything, I think she's on the line, or if there are any questions, happy to take them.
Very good. Thank you very much. Anything you want to add, Zoe?
I think the only thing that I would add is that it is annual staff survey time again. So it's during this week that they're being posted out, so people will start to receive them this week. So to our staff governors in particular, please take the opportunity to fill that in. We're posting them out to home addresses this year to obviously to reduce touch points, to make sure that they get to people. And just looking at Denise's comment in the chat box, Sarah Turner Saint's done an absolutely fabulous video talking about the importance for people to fill that in and why we're doing it a bit different this year, which has gone out on social media this week, and it's great. If you've not seen that, I would recommend it. And Luke's going to tweet, thank you. I tweeted yesterday, so you do today. One a day would be good.
Very good, thank you. That's good. I don't think we have any questions for now. Again, thank you very much.
Could I ask one question on that, please?
Please.
Please. Why is the staff survey needing to be sent out by? But is there not a way that you could actually do that online to save postage costs?
Shall I answer that, Jeremy?
Yes. Thank you.
Okay. The reason we've chose to do it postally is basically on the back of what people have said to us in the past. So our people in the past have consistently given us feedback that they prefer to do it in the paper way rather than electronically. So that's the reason that we're doing that, and the kind of paper-based method we've used in recent years, but within the hospital. And we have sort of encouraged people to do that as teams and have a bit of a staff survey tea party, etc., which obviously we can't do this year, and we're absolutely not encouraging that this year. But the feedback that we've had generally is that there's more of a preference for continuing with this kind of something that you can hold. So that's what we're going with.
And there's a long history to this, Deborah, which we won't bother you with now, but very briefly, we had very low staff engagement with the survey. But worse than that, we were a bottom quartile performer in terms of staff satisfaction. And we've really increased the level of engagement with the survey initially, and now we've increased the levels of satisfaction such that we're above the national average on, I think it's 9 out of the 10 measures, and we're just at the national average on the 10th measure. So we've made huge progress. So, you know, on one level, you think this is completely Luddite behaviour in the year 2020. But given where we've come from, we're loath not to make whatever investment it takes to maintain that dialogue and to demonstrate our commitment to engagement, and with the hope and expectation that we're going to go from strength to strength in that regard, because our ambition is to be not at the national average or just above it, but to be a top quartile performer, on the basis that if you've got happy staff, you've happy patients, and everything else flows in a good and virtuous circle from there. But thank you for the question. So we're going to move on now, if we may please, to Atul, who's going to give us an update on some aspects of system working, please.
Thank you, Helen. Good morning, everyone. This is getting to be more of a compendium item. Innovation is going on in many, many places, as hopefully governors have seen from colleagues who reported earlier on. Helen has, of course, updated us on the present situation with the system. So thank you for that. And we're going to get something from Tony later on in terms of the phase 3 recovery angle. So, I mean, the great news is that COVID, in a way, has given us a big spur to getting innovation and new ways of working going and getting embedded through the ICS structure. I found myself a little bit, though, on a kind of management speak gobbledygook watch recently, when the centre has hoovered up all these good ideas and then came out with a set of recommendations which I couldn't make head or tail of. Again, the good news is that there's a lot of practical things going on, and that's what we need, practical service delivery models that are innovative to benefit patients and staff.
Thank you very much, Atul. I'm going to move on to Mike, if I may please, Mike, to do the update on procurement, and certainly feel free to do any wider DSFS updates if that's appropriate.
Sure. Morning, everybody. Thanks, Helen. I'll stay off camera because I've got a very weak signal again, so I'm afraid it's just voice at the moment. It's a very short report update this time. I think there's 2 sides to the procurement agenda which I'd like to point out. There's the actual, is our procurement function working better than it was, and are we showing continuous improvement? And I'm pretty certain we are. And I'd like to thank Angie for her comment at the annual members meeting, if anybody remembers that. About I think if I misquote you, I apologise, Angie, but I think we were only out of stock on one SKU for 2 hours or something. So clearly the procurement around PPE in particular is working. The second side to this is these very difficult to achieve or very difficult to measure NHS standards, and we've got the first of the 3 standards under our belt, so that one's accredited, and we're well on the way to trying to get a programme to deliver level 2. Now, I talk to Lee about this fairly regularly, and Dennis almost every week in our weekly updates. And I think, as I pointed out in the last update, the first level accreditation was all about the department itself and was fairly insular. And we've ticked all those boxes and we're moving on. The second and third accreditations are hospital-wide. Now, there are something like 30 different grades of category to tick box, and there's about 100 different bullet points across those 30 subsections that we need to try and put a tick in a box to make sure that we can get level 2 assessment. I would say that we're probably about 25% of the way through getting ticks in those boxes. I need to sit down or virtually sit down with Dennis and come up with something a little bit more tangible, because at the moment the update feels a little bit woolly, and I am nervous, and I had this discussion with Lee about how these updates will look going forward, because it's kind of like a binary situation. You've either got the accreditation or you haven't, so progress towards it is always a little bit difficult to demonstrate, but we will try and come up with a way where we can show how progress is against these sort of 30 subsections and 100 bullet points. If anybody's ever bored, as I said last time, you should Google the NHS procurement standards, and there's a 23-page document that you can see that we're working towards. So progress is good. I've got no issues at all with the way the procurement function is working. I guess my issue is how we try and demonstrate that succinctly in this type of environment. And that's the challenge that I'm now working on with Lee and Dennis, to make sure that we can give you something that isn't too waffly and something that's a bit more quantitative about what our progress has been. I haven't pushed it too hard yet for obvious reasons, given the COVID environment. And I was hoping that with COVID getting back to perhaps sustainable levels and restoration and recovery kicking in, that we might have a bit more opportunity. But I think I don't want to push it too hard when we might be going into another, PPE emergency situation. So we're on the case, but it's going to be quite difficult to actually demonstrate to this body how we're making progress against level 2. But we are thinking about how we can come up with something succinct, if that makes sense.
Thank you very much, Mike. Keith, I'm not proposing to go back to you on digital, because we had that helpful update earlier in the context of system working. But I'm going to pause, because sometimes if you don't have any particular thoughts or reflections on an individual aspect of the update, if anybody has any reflections on the kind of operation of the hospital as a whole now, having had a cant around all those areas that you've previously indicated to are particularly high in your agenda, we'd be very happy to have that conversation now. So as I say, just an indication in the chat box or raise a hand if you want to do that. Okay, I think that must have been all pretty clear. I'm very grateful to colleagues. I hope it has demonstrated to our governor colleagues the extent to which NEDs have been very much engaged with their executive colleagues on a regular basis, and despite the constraints and limitations of working in a COVID environment, that we've been able to, as a board, continue to give the leadership to the organisation and necessary oversight and assurance to its Council of Governors. I think it's a really helpful report in that regard. So I'm thankful to colleagues, and also for the fact that it's so easy to hear you on the page. So you've definitely given thought not only to your presentation today, but to the update. So thank you. I'm going to move us on, if I may. So the next item on the agenda is the restoration and recovery item. And I'm going to pass across to Tony to lead off on this, please.
Good morning, everyone. Thank you, Helen. I'm having terrible trouble with IT today, so hopefully either John or Nicola have got my slides. I will also try and bring up to date and knit and make reference to several of the comments that have been made already. But if you can just nudge a slide on for me, Nicola. Thinking of Angie's words earlier, my favourite topics, yeah, testing might be one of them. But this is a lovely challenge that we're presented with as a system. Coming forward in the next few months, prepare for a normal winter. Prepare for a second wave of COVID, and I'll come on to that a little bit more. To restore and recover all essential services, and don't forget, you know, in normal times there's the usual flu stuff. The flu raises its head as a particular high volume activity. We've got a number of patients. We've also got to think about how to cohort those. Just go on a slide more. So just very quickly, balancing the urgent care pathway, pretty much now our activity, the number of patients coming up at our front door, coming through ED, etc., are pretty much at normal levels, and the team are doing fantastic at maintaining a red and green sort of pathways through the department. Our compliance levels is regularly above 93%, and we do have some good days where it actually meets the target, so much better. Preparing for a second wave, again, I'll add detail to this because certainly the modelling we were thinking about was it might peak in December, but you'll have heard from Boris last night, it might be a little bit sooner than that. Angie's already mentioned our current status of 4 patients, so I'll not go over that. What I will say, though, is we're starting to see in our primary care space and in our hospital rising numbers of suspect, which takes space in the hospital beds along that pathway for us, and if you like, consumes the capacity of our testing capability as well. So it's heating up, and right across the system, increasingly we're seeing hearing of numbers within community and primary care where patients are presenting with symptoms. I know there's a bit of an ask, you know, tell us in detail, Tone, about all of our services. Where are they in terms of restore? Actually, all of our services, if I take the shortcut, all of our services are restored, just to different degrees. And I'll elaborate on that as well in a couple of slides. And performance is improving in different aspects. So, you know, you may recall during the peak of COVID, like I just mentioned, urgent care, the attendance plummeted, but equally 2-week wait referrals plummeted. But they're now back up to normal levels, which is reassuring in terms of patient care. Going through from there, there's equally managing flu. Now, actually, before I go on to flu, colleagues have made several references to Royal Primary Care. Royal Primary Care has adopted the national approach. I'll just give you a couple of stats. You know, 80% is non-face-to-face. So they've held on to that. But as I think Ruth said earlier, and Keith said, you know, all of the patients are clinically reviewed, and if they are appropriate for an appointment, then absolutely they get a face-to-face appointment. The Red Hub, where you've got your COVID suspect patients, continue to work well. So Royal Primary Care in a good place, relatively. And then the flu season. We are trying to accommodate that as well. So we've started vaccination, and I think Angie had mentioned the clinic started this week. So the first one had 110 on this site, and I think there's something like 1,000 patients been visited out in primary care space. So really good start. So just move on. Part of the challenge with running the hospital, it almost feels like about 4 hospitals really, with all the different pathways, is pre-COVID, we were very nimble and flexible in the way we moved our resources, people resources, around different pathways to cover each other. Now, though, if you're covering, many people ask me why are we struggling with some of the restoration, Tony, in terms of volume and getting back to pre-COVID levels or near pre-COVID levels, is because once you've rostered and put the staff in against a pathway, they have to stay there. They can't keep moving across the hospital and the pathways. And I'm really proud of the whole team, because we are a hospital that hasn't had any outbreaks. So the way we've managed the pathways and adopted the infection control guidance has worked really well. So very robust pathways we maintain. Daily meetings from an operational point of view, which involves our infection control colleagues and all areas of the hospital, to make sure that we interpret the guidance, which I think colleagues have said earlier, changes pretty much daily, and we have to adapt daily. Really key that the fact we have no outbreaks is because we do place our patients on the right pathways from the point of entry. I think I probably had a couple of examples over these few months whereby I might have thought, how did that patient get into that part? Otherwise, exceptional. Same challenges with equipment, and our colleagues in procurement has already been mentioned. You can't move kit across different pathways. So that's challenged us, and we've had to procure and invest in our kit to do that. Likewise with staff. Why is it that we can't restore some of our theatres or some of our areas? Is because we've had to learn through the COVID period that it requires more resource to don and doff and support colleagues. And basically, again, they can't move across different areas. So we've invested heavily in additional staff to cover that. So in a very good time of fashion. Discharge. At the height of COVID, the system worked exceptionally well. There were lots of things that made that easy to do, but maintaining that has proved difficult. If we can't discharge at the same rate we did in pre-COVID, then you can imagine my urgent care pathway and bed stock will fill up. And if that fills up, I don't have the option of using it for other things. I'll come on to that in a minute. And clearly, we continue to restore and recover. So at the peak of COVID, there were hardly anybody turning up on the urgent care pathway. We were absolutely able to configure the hospital in a way that coped with suspect COVID and COVID, both in our bedded areas and our ITU areas. And we weren't doing much restore and recover, although we maintained all of our cancer work. Whereas now that's somewhat different. So if you just move on a slide. I want you just to familiarise you with the fact that we've had to do a significant amount of modelling in line with the national guidance and regional guidance. If everything came together, because we have to assume winter normal, what if COVID happened at either 100% of the peak in phase 1 or wave 1 rather, or 75% or 50%? What is the likely impact on us? And the likely impact, what this is demonstrating, is our reasonable, most likely case, assuming a mid-December peak, is that we'll run out of beds in December and January. And what I would also say to you is because those pathways are exhausting all of our beds, it'll happen before then. We always still try to hold on to all the good stuff, as we always have, around our length of stay management, etc. That's where the discharge is important. So there's a series of assumptions. As it currently stands, if they come in together, we will not have enough beds to cope. And hence the first thing that we will stand down, as much as we're trying to stand it back up, is our elective work. That's a fine balancing act that occupies my lovely life every day at the minute, and my colleagues, in terms of that fine balancing act. So what you must, if there's one message I leave you with today, you're used to me talking to you about the winter plan. Bearing in mind it's September, where I would normally say we normally have a ward free just for, if we're upgrading our organisation in terms of different wards. We normally got a couple of wards in reserve for the escalation of winter. All wards are in use currently for different aspects of these pathways. Can't stress that enough, they're all in use. So if we just move on a slide. So this is the challenge, these different pathways. We have as you're used to me, we think through the scenarios that might happen, and we continue to think through them at the minute. We have very, very fine, detailed escalation plans. We know exactly what we'll do if certain circumstances happen. What I will say to you that complicates it it's a bit of a race, really, in terms of bad news. If our urgent care pathway does materialise as a normal winter, will that happen early? If COVID takes off early, they're racing for the same use of the beds, as is some of our elective workers who stretched out. They all, at a point in time of our escalation plans, they all want to use the same beds and they all can't fit in. So we do have a challenge. It goes back to that bit where I say we run out of beds. So next slide. These are a few things. So why, just to elaborate a little bit more, why is it so difficult then, Tone? What's the problem? Why can't you just do everything? Hopefully I've given you that first one, the different pathways and the infection control guidance. Means our staff where we have allocated need to stay on those pathways. We can't move them around in the way we did before. Clinically, all of our patients are reviewed by our clinicians. And so we've been treating the most clinically appropriate patients, which actually is at odds with some of our targets. So one of our greatest challenges in the elective side is 52 weeks. For the most part, all of those patients are reviewed, but for the most part, they're not. And so our 52-week positions deteriorated. It'll improve a bit over the next few months, but not massively. A simple maths, if infection control guidelines says that you can only see half the patients, then to see the same amount, you need twice the capacity, which we just don't have available to us. And then we've got to manage the volume of patients on site, whether it's in our inpatient or outpatient area. Same with visiting as we've done before, to keep the place safe for our staff and for our patients. Discharge I've covered. Patient confidence is a big issue. I really, you wouldn't believe the number of patients who turn around and say, do you know what, I don't think I'll have that treatment. I'll wait until it's all over, which, as you know from Boris's announcement and the way things are going, that ain't anytime soon. Testing, one of my other favourite subjects. Testing at the minute, absolutely only asymptomatically, or symptomatically, sorry, gosh, symptomatically only for our staff. There's lots of issues with society, with going back to schools, going back to work, where people are showing symptoms, which then takes out, remember the early stages of wave one, takes out our staff. That's starting to happen again. And then what's known as Pillar 2, where society can go to gov.com and book a test. You're all hearing the news at the minute that they have serious capacity issues, and they're leaning on the NHS provision, which I coordinate for our region, which is overwhelming as well. And to do restore and recover in a safe way, we also want to bring in some of the testing at the front end, so we don't need them to self-isolate for 2 weeks, which again puts pressure on the testing. Whilst we're doing all this, we're trying to maximise use of the independent sector, not just for traditional surgery. We've put dermatology out in our independent sector because we can, and it frees up space and time and management of our waiting list. So just move on. So, next slide, please.
Struggling to get it to move at the moment.
There's only 2 slides left. This one's really important as a summary. The slide that's going to come up when it does summarises the key elements of the ask of the phase 3 letter that Simon Stevens put out, and basically says where we are as a system in terms of our ability to meet those. You're almost there, John. What it shows is the Derbyshire systems position. Next one, the one with all the colours, John.
Can you see that?
Not yet. What it shows, if I ad-lib a little bit more waiting for that, is that we are really struggling to restore all of our services, particularly our electives, to the there we go, to the level that we've been challenged with, that we've been asked from a restore and recover. So as you step across, you can see the different activities, the NHS target by month, what the system of Derbyshire's performance, UHDB and Chesterfield are. In terms of the elective space, it's probably worth noting that probably about 85% of the demand is at Derby end. And you know, when we talk about they're falling short by significantly, almost 10 times the volume that we have. But we have challenges restoring all those for the reasons I've described. So just very quickly, from a diagnostic point of view, actually we're in pretty good shape. It's only our endoscopy that we're not quite delivering against last year's targets. And the only reason we're mainly doing that, apart from bringing our services back online in a controlled way, is actually the national screening programs, which isn't in our control, was stopped dead in their tracks when COVID hit. And they've only just restarted with letters going out to patients to come in for a screen. And that's where the difference is. That's why we haven't recovered that. But on all the others, it's because of that balancing act that I've described amongst the different elements. My last slide, John, just in summary, is, if not challenging, I didn't know what to put after the dots, immensely challenging. Never had such a challenge, load of fun. It's exciting, but it's challenging. Everything we're doing is to make sure our patients are safe and our staff are safe. So absolutely our focus. The teamwork across this hospital from everyone has been fantastic. And we haven't taken, if there is such a thing, it's harder, I think, to operationally deliver all this challenge and significantly transform the way we do things. So just those couple of stats, I think I've said 80% in Royal Primary Care from non-face-to-face appointments. And I think Sue mentioned we've gone from 4% to 86. And as things settle down and clinically it's appropriate that you see a patient, then at the minute, even our first outpatient appointment, we're sitting at 40% is non-face-to-face, and our follow-ups are at 60%, which is, again, exceptional. I'll draw breath, Helen and Angie, if that's okay, and colleagues, and I will take any question.
Well done, Tony, tour de force. I mean, my only comment will be, despite the fact that we're challenged to, and there's a lot of red against that slide, against the NHSIE targets, I wouldn't like governors to get the impression that there isn't a huge increase in the level of patients we're seeing. I mean, that message needs to go hand in hand with the message about, you know, every ward is now, you know, back up and more or less at full capacity. And that we are seeing huge improvements day on day about the number of patients we're managing to get back in and get on their appropriate pathway. But the tension that sits under that last slide is a tension between those in the front line who are making certain judgments about risk with those who are in national roles and quite rightly want to see, you know, virtually 100% of pre-COVID levels of restoration. And I think it's a sign of a healthy system that those two things are in some tension. The ambition is right, but I think also the caution that you and colleagues in the hospital are introducing into the detailed planning of what's possible is really important in the interest of keeping patients and staff safe. So, you know, despite that sea of red on the last slide, I think it shouldn't detract at all. Number one, from the amount of planning that's going into getting patients back, but also the reality of the amount of patients that are now coming through the hospital. So well done. If we could go back to the pictures, please, I'd be grateful, just so I guess glimpse of at least somebody. That would be good. And I just see if there's anybody who'd like to raise a question on the back of that. Some great comments, Tony, about a good presentation, and of course people recognising it's an ever-changing picture. But would anybody like to come in there? If you would, please just indicate in the chat or raise your hand. No? Again, well done, Tony. I'm going to suggest that we have a couple of minutes comfort break. I'm conscious that we are on the last lap, but in the last lap we're going to share the issues that came up in the Governor's pre-meeting and also take some feedback on the annual members meeting and get some feedback from Margaret's committee. So I'd be keen to do that justice. So in the interest of doing that, it's now 11:51. Maybe we could take 5 minutes, no more, and come back just before 12 o'clock. That would be much appreciated. So we'll reconvene then, and I feel confident we'll still conclude the meeting on time. So of course not all colleagues were with us at that stage, so I'd just like to give you a quick recap. The first item really came up in conversation about the adequacy of our arrangements to support governors dealing with the hospital virtually if we anticipate this going on for some time. So I think, you know, we can anticipate it going on for some time. So some people have old devices, some people have a single device that's not allowing them follow papers and be on the screen at the same time. A number of issues like that. And I think it will be sensible now, please, a request of Angie and of Nicola, that we take stock. We'd normally be supporting governors in a particular way if we're having face-to-face meetings. The need for that has gone away, but I think we do need now to replace it with sensible support with respect to virtual working. So if you could give a bit of thought to how it might work best and consequently what it is governors might need, and we get that in place, because we're very grateful for the kind of speed and alacrity with which you've moved to virtual working, but we do want to do everything we can to make sure it's as easy for you as possible. So we'll take that one away.
Yeah, happy to do that, Helen, thanks.
Thank you. The second question was more of a musing than a suggestion, but it's about engagement on site. So we spoke about the fact that NEDs weren't going to do visits on site until patients could have a visitor. So when limited visiting came back, NEDs started doing visits. With the exception of the trial run you, Beverly, and I had, Angie, on that virtual visit, we haven't really made them get up and running or stick. There's no program of them, you know, they're not happening regularly. But we thought it would be really sensible to get them up and running now, in anticipation that we're not going to have, you know, a range of governor visits taking place. They're already up and running in the community trust, and they're just about to start in Derby and Burton. It's most unlike us to be behind any curve in respect of governor innovation. So as you can imagine, I'm keen that the situation is rectified shortly. So I think we do need to get those up and running. It begs the other question about whether or not there should be some limited sense of governors coming into the trust to do visits. Because Margaret raised it in the context of, if we're trying to tell patients that it's really safe and fine for you to come to the hospital, but governors are staying away, does it send a particular message? But we didn't reach any particular conclusion about that, because obviously, you know, the balance of risk, if you need to come to the hospital for a procedure, you know, there's a clear balance of risk. Whereas, you know, we might just be adding to the infection control burden. So we said we just have a think about that, and John's already taken an action in that regard. So we will come back to you soon. So we'll immediately sort out the virtual visit, and we'll come back to you soon about what's the balance of risk around visits by those governors who feel that they would like to do them at the appropriate point. But that then led to a separate but associated discussion about flu jabs. So there was a request about whether or not we could add governors to the list of those who could access their flu jab at the trust. And Nicola's already taken an action to take that away and see how it might best work. If indeed that does work with the other pressures on flu jabs for frontline workers. But I'm assuming that given the national edict for everybody who moves to get a flu jab ASAP, that we will do our best to work out the art of possible in that regard. The RPC access issues got raised, but we've dealt with those in the course of the meeting, so I don't think we need to pause on those any further. And we had a written question from one of John's constituents who had approached him. And Greg Strachan has very kindly offered to take that question away. I suggest that Tony might be able to help Greg in responding to that question from the hospital's perspective, because it was about the prevalence of COVID in care homes, the impact of discharge from secondary settings to care homes on infection transmission, and the kind of management of the whole situation in respect to care homes. So Greg's kindly offered to look at it from a community perspective, and I'm sure Tony will be happy to chip in and help with the discharge elements of all of that. So John will get a response in due course to that. And the final question we looked at was in relation to patient transport and the care of patients, both in terms of the length of their journeys and in terms of any increased exposure to COVID transmission at this time on normal or indeed lengthy journeys. So I have agreed to receive some correspondence and to seek a meeting with Pauline Tagg to talk those issues through. Now, have I forgotten anything? If I've forgotten anything, wave at me vigorously or indicate in the chat box.
And then there's just a question from Judith for you and I that I thought may be easier to talk rather than type.
Very good. Yeah, please pick that up, Angie.
Which is how we're looking after the exec team. So thank you, Judith. I think it's important that we talk a lot about looking after our workforce, and I consider my job looking after my team to be part of that. So slightly under pressure because they're all looking at me, but I try, and they can challenge me back now, to make sure that we do look after each other. Helen does a marvellous job of looking after me, and so do my NED colleagues and my exec colleagues, which is a whole range of making sure I move a lot at the moment, so my achy back gets looked after, challenging me on when I'm looking tired. I've got some very honest colleagues, and how my expressions change, so I go home and have a word with myself and asleep. Keeping our sense of humour, as you may know, that is, may have gathered, that's one way that in this very challenging world that we do, and we have our regular team catch-ups to support each other, and that's an important part of it. All exec team have access to the same services that we offer to all our staff in terms of counselling, health and wellbeing support, etc., etc. And the last comment I'd make is my measure of how well I'm doing is when I actually spot some of them working from home or going home at an appropriate time and switching off a little bit, because as exec colleagues, we're not very good at doing that. And I keep reminding them that we have to lead by example. It's really difficult at the moment when we're giving a message to all our staff to say, don't come in if you don't have to. And some staff really find that quite hard, versus the others who would quite like a day working from home, and clinically it's just not doable. That we have to lead by that example, which I say not always very good at, but some of them have been very good lately, so I think I'm getting there. And it is going to be a really tough winter, so we're just looking at diaries again about how we have a bit of a tag team, so we're not all in the building at the same time, and we protect our leadership around that again, as we would expect all our staff to do.
Thank you.
Thanks.
Yeah, I mean, yes, it was a very personal thing looking at your faces, but it was also, if you don't mind me being blunt, have we got all the options covered in case one of you gets the flu? Let's not say COVID, but gets the flu when you're working on such a huge range of things. I assume that we can feel reassured that every option's covered.
Yeah, and that's part of having that team where we share responsibility, and we use our deputies. The thing we've slipped back on a little bit as the whole NHS and the whole world as all the meetings and everything coming back in. And Tony and I had a discussion this morning about, 4 of us are all at 5 different meetings this afternoon, so quite how we do the maths on that one. But those constant reminders to yourself that we don't all need to be in one place, and make sure that we're covering each other and our teams, and making sure we do have the holidays, the long weekends and the breaks. And I'm now going to go do my makeup. Thanks, Jude.
No, I just thought you might be looking a bit tired.
I've got the message.
Well,
did have a late night last night. I'll have an early one tonight, I promise.
We had a message from David Lyon, Angie and I, the other day. I don't think David's on the call. I haven't noticed his name. And he said he thought we were both looking 20 years younger at the annual members meeting. So we were debating whether or not that was a compliment or just a sign that we were a bit overstretched at the moment. Now, we've a number of questions in the chat, so thank you for the prompt about that one. The other one that's here is about testing and in-house testing and external testing and getting staff back to work and all of that. And Tony has pointed out that it would probably be better to take that verbally too. So who'd like to do that?
Shall I do that as one of my favourite topics?
Very good. Good man.
So just a reassurance about patients. So if a patient arrives at our hospital by whatever access point, but let's just say predominantly through ED, they're swabbed in ED if they're going to be admitted. If they're going to be admitted, not if you're not going to be admitted. So if you're going to be admitted, you're swabbed on admission. So I just wanted to assure colleagues on that. And from a discharge point of view, if you're going to go to a care home, then against, once we've got the build up towards an expected day to discharge, then 48 hours before they're expected to be discharged, they're tested again. And so we should have a result back by the time they leave. So that's just the ins and outs from a patient point of view. And increasingly with some of our restore and recover, you're required to isolate, then get tested 3 days before your procedure and then come and have your procedure. Well, clearly we've relaxed that a little bit, but on different aspects of our restore, then we're introducing testing, which is easing our ability to do the work or adding a burden to a very limited capacity. And then the other question about is it political around testing all of our own staff, etc. In my favourite subject, I have the joy of looking right across the East Midlands, so I can see the picture. And I think I've said to you before, the supply chain is very fragile, still remains that way. Testing asymptomatically, you'd have to do it every day. And we just don't have the capacity as an NHS to do that. And so you get a result today and it says that you're negative, that's fine. Right now you're negative, but stuff can happen tomorrow and it can change. There is a big challenge, I think I mentioned earlier. So even if you were outside of the organisation and you were displaying symptoms, the key is you've got to be displaying symptoms that then really go and get a test. If it's just, well, I'd be interested to see what the result is really a waste of the resource. So that's the challenge. Across the system at the minute, the government is announcing pretty much daily, sometimes lots of times without even talking to the labs, that we're going to scale up and deliver this daily, whether it's 800,000 or a million or whatever it is. That's a massive scaling up, massive. But they're the different elements. Patients are safe at the point of entry into our hospital. Patients are tested and safe for their onward journey, certainly to a care home. Staff are tested appropriately, and we have that right now. We put in provision locally here and at our PROAC centre to test staff who, because of family reasons or other, are having to isolate, and we're testing them quite quickly. And that's only just been put in this week because we are supporting the Pillar 2 activity. Hopefully that's not too long an answer covering all those
No,
points.
that's a great answer, Tony, particularly picking up care homes. On the staff issue, I think I might have given colleagues a wrong indication earlier, because I thought we were managing to, between the PROACT and the hospital, get staff through quite rapidly, particularly where they had very important patient-facing roles. But we've had something on the chat earlier from Ruth about the fact that her personal experience wasn't great. Now, whether or not that was before we this new way we're working in place or not, I don't know. But you might just want to have a little look
I
at
suspect that was before. So
that was Saturday morning.
Yeah, and it
Saturday morning was the government test, and yesterday morning was the PROACT test. So just coming into this week.
Yeah. So the reality from the government side, what we refer to as Pillar 2, etc., that has had immense problems in recent times. And I've got more examples than I really care to have, both here and across the region, of where staff or Joe Public is going to a testing centre miles away, absolutely miles away. It's hopeless. So that's been a big problem. So this week, I think it would have started on yesterday, whereby we put a different system in place to allow our staff, who are high risk and clearly key to the services we deliver, to have access to test at that place. And we are delivering, the NHS labs, not Pillar 2 labs, are delivering the testing to allow that turnaround time to be good.
To what extent are we able to support other providers or primary care providers in the system in that regard, Tony?
So there's a testing cell that has all of the system partners on. So whatever I say in terms of testing, I don't just coordinate it for CRH, it is available to the system. So we have initially, nowhere near enough, but it's all the capacity we have. Initially in Derbyshire, we're making available 75 tests to staff of this situation, and we'll review it on a daily basis. And the reason it's only 75 is because the labs are already supporting patient testing, which is priority number 1. Patient testing from a restore and recover, priority number 2. And those elements. So they're right at their capacity limits. And then we've got national, regional, local conversations about how to increase capacity against a provider network which is being stretched worldwide.
That's really helpful and fabulous to know that that increased capacity for staff has been made available despite all the other pressures. So well done, Tony. We've got questions now, please, from Mike Rundman and Janice, in that order, please. Hey there, Mike.
Yes, I'm here. I didn't raise my hand, actually.
Oh, sorry. I thought Tony, yes, please, meant you wanted to come in. But
No. I just wanted Tony to answer the question, which he has done.
Very good.
Thank you.
Very good. In which case, let's go to Janice, please.
Sorry, I just wanted to ask around the staff testing. Has that been communicated? And apologies if I've missed that, but I wasn't aware of that. Has that gone out that staff can get easily tested at ProAct then? Say apologies if I've missed it, but it's not something I was aware of.
It will only be in the last 24 hours, so it'll be out there, because I know I was working with the General Manager in Integrated Care and Sarah on the briefing material. And it would have been discussed within the system Monday with all other partners as to their share and how to access it and all those sort of details.
So it will be filtering through them.
Oh, absolutely, be filtering out. And I think I probably put it in I put several blogs out because things are changing so fast at the minute. I think I teed it up for a fuller briefing.
Okay, thank you.
Very good. Now, Mike, have you put your hand up this time?
Yes, I have put my hand up. Actually, it's just a simple question. Where are our patients who have the swabs taken in A&E or wherever? Which lab actually tests them?
Our labs.
Here in Chesterfield.
So Derbyshire Pathology is a combination of Derby and Chesterfield. So the tests will be taking place on both sites, and they help each other out in terms of excess volume. So if we get overwhelmed, Derby, but it's one organisation anyway.
Yeah. Okay, thank you.
Very good, thank you. Great update, thanks very much. So I think that probably covers the issues that were raised in the Governor pre-meet. So I'm going to go on now to Governor feedback session, item 8, please, and just ask governors for their thoughts and reflections on the annual members meeting, please. Denise, would you be kind enough to lead off?
Yes, Ellen, I thought it was really good. I thought it came over very informative, but honest, which I liked. We didn't really say, or you didn't say everything was wonderful, but you gave a really broad overview of the situation and how it's gone. So as I said to you, a couple of friends were watching it as well because they're members of the trust, so I got some feedback from them as well, which is always useful because they're not governors, they're just members of the public. And a friend of mine thought it was very honest and open and gave a really true reflection. And she was very pleased about the videos with actually getting it from the staff, so to speak. So it wasn't just you and Helen saying, it was actually members of staff that were giving their own experiences of the COVID journey. So all in all, I thought it was really good.
Thanks, Denise. Would anybody else like to share their thoughts? Luke?
Yes, again, similar to what Denise just said, the content of it was very honest and open and transparent. And I think the other thing to touch on was how it was actually presented. So I've noticed some other trusts doing their annual members meetings over Teams. But actually, I think that one that we did kind of stands out now. It was a bit different. So yeah, I think actually how it was presented, how smooth it ran was absolutely brilliant. And again, friends and family have mentioned to me how slick and professional it looked. So brilliant, well done.
Thanks, Luke. I was pleased with the fact that it is accessible to more people. So I think we had about 130 on the night, but I don't know what the up-to-date figures are for anybody who watched it subsequently. Because I'm always conscious that when we have it face-to-face, not everybody is free to turn out on a, Tuesday or Wednesday night in the middle of September. So hopefully we've managed to make it accessible to folk that wouldn't otherwise have been able to come, even in a pre-COVID world. So we'll probably need to give a bit of thought to, when things do go back to normal, please God, how it is we maybe do a bit of a mixed model so that there's still the opportunity for people to join in remotely. Angie?
And just picking up on that, Helen, I had feedback from a consultant member of staff who said in all the years they've worked here, they've never actually made it to one, but because of the access, found it really easy to watch and very complimentary about it. So it's just an interesting reflection around our own staff as well and their access to it.
Well, exactly, really important. Yeah, very good. So if we can move on to the Involvement and Engagement Committee, please, Margaret, just to have an update in terms of where you're at.
Yeah, the last meeting we had was on 30th of July, so it's just a while ago. And we had an update on patient experience. The national RPC survey was fed back to us. We talked a bit about access. Patients were saying that access had improved, but there's still some issues around it on that. But and the other thing that was commented on was patients not being able to speak to the preferred GP, which I know is always an issue that patients raise. But we had an update on that. We had an update from the communication team, which just talked about, highlighted the piece that Lynn had in the Reflections magazine. I don't know if any of you saw that, but it was a very nice article that was in Reflections. And we discussed some ideas for the membership magazine. And then we had an update from Richard about volunteers and what had happened during the COVID period and also what was happening for the future. So that was a really useful update to get back together with. And as I said, that was it. We did talk about things for the annual members meeting and the engagement strategy, which had been accepted by the board. So that was the gist of the meeting that we had. And we've got another one, I think, next month. I can't remember the date. Don't but it's good to, you know, to keep in touch. We didn't actually have any of the members of staff, any of the senior nurses at the last meeting, but you know, maybe we'll need to get engaged with them again to see how things are in terms of the recovery at our next meeting, but we'll discuss that for the next agenda perhaps. Okay.
Very good. Thank you very much, Margaret. Anybody want to raise anything with Margaret?
No, I was just going to say, I think with us moving back towards the virtual ward visits, that will help us get the staff back involved again, Margaret, as well.
Yeah, yeah.
I know when Andrew's managed to join us, we've had some really good updates from Andrea. So I think now.
Yes, the previous meeting, it was really good to have Andrea.
Yeah, she unfortunately she was on annual leave for the last meeting, but she's got the next one in her diary. But I think hopefully once we can get back online with the virtual ward visits, that will help with the engagement committee.
That's very good. Thank you. I'm going to move us on now to a number of items that are under the consent section. So in the consent items, we've put the minutes of the last meeting, the performance update. So obviously the protocol around that is that you advise the chair in advance if there's anything you want to raise. I shall be indulgent, and if anybody wants to raise anything now that they haven't previously advised, please feel free to do so. No, in which case we shall consider both of those agreed. And we'll move on to item 10. Any matters of other business? Any AOBs? No?
Helen, just a technical thing. If information is going out for testing for Prague Stadium, the name has now changed to Technique Stadium. Sorry.
Thank you, Norman. I wasn't aware of that.
Nicola, we want to talk about the CoG evaluation, don't forget.
Yes.
We do,
yes,
yeah.
Please.
No, I was just about to mention that. Do you want to do it, John, or do you want me to?
Well, I'm happy to. It's just to mention that we've got the CoG evaluation scheduled for the 7th of October. If people are okay, we thought about moving it along to the 17th of November. The real key reason really is to try and make sure we manage the remote evaluation aspect of it as well as we can, and to try and make the software approach we use the easiest we can. We can currently do it, but we did a trial yesterday, and to be honest, I think it was a bit probably too involved, and it would get in the way of the flow of the conversation. So we're looking at moving it along, giving ourselves a bit more time to try and give the event the way we want to do it. So I don't think unless there's anything else you want to add to that, Nicola.
I think, can I come in there, Helen?
Yeah, of course.
Please.
I think we need to be a bit clearer with governors what you mean, because what you mean is actually that tagging it on to the Council of Governors meeting. And so I think in terms of timing and things, I think you just need to explain exactly what you're proposing to do.
Yes, it would be before the Council of Governors meeting. You take basically an hour or so before it starts. That's what we're looking at.
So that's the suggestion. I mean, my only comment to add to that before we open up thoughts are meetings virtually are much harder. They require a different sort of concentration, which is why I'm always keen to inject a break or two, because you just need to stand up and kind of move around and do something. And I'm a bit concerned about adding another hour. Might feel a bit much for some governors. I mean, I think us folk who spend all day on these things have just about kind of managed to do it, but I wouldn't wish to inflict it upon you if you thought it was going to detract from the quality of the discussion and the rest of the meeting. So that's the proposal, but we're very happy to take other proposals or arrange a separate event on a different day if that's what you prefer. So please do indicate to us now what you prefer.
Yeah, because I was keen that, because it's the last Council of Governors before the end of the year, so I didn't want it to detract from the business, given that we only do the virtual ones. So I was keen that governors knew that how much extra time it was, and I didn't want it to detract from the council. That was all.
No, that's fine.
Yeah.
I'll take that on board, and I think I'll look at holding it on a different session. I think, as John alluded to yesterday, we tried to do a trial run, and given how we're trying to do everything virtually at the moment, we just want to ensure that the program and the software that we're using, we trialed it last year in person for the first time, and we were all in situ in the same room. So add into that we're trying to do something that's new again virtually. We just want to make sure that we've got it all streamlined. So completely take that on board. John and I will look at holding it on a separate date, and I'll share that with you all in due course.
Yeah, yes, we will. Yep.
There's a lot of nods, so I'm assuming that would probably be the preference. Yeah. So thanks for that. Yeah, and good to have considered the options. So thank you for thinking that through, John and Nicola. Very good. So the next items at 11 are just items for information, the minutes of the Involvement and Engagement Committee and the Forward Work Programme. So that brings to item 12, which is the date of the next meeting, how the year is flying. The date of the next meeting is the 17th of November. And last but by no means least, a review of the meeting. So how did we do?
Very well, I thought.
Yeah.
Very good.
We still seem to be getting through the business, don't we, despite the fact that we're having to adapt.
Yes, I think the right length of time, given the nature of having to do it on the screen and what have you. My concentration's just about lasted, I think.
Yes.
Well done, well done. Well, thank you for that. We don't have any questions from the public because I've had regular updates from Gillian as we've gone through, and we haven't had any members of the public join. I'm not that perturbed. I mean, obviously it'd be good to have members of the public join, but I think it's really important to make the opportunity available. I'm sure if we had any contentious business, members of the public would really appreciate the opportunity to join. And again, a bit like the annual members meeting, whilst we had about 130 on that night, we've just had an update from Sarah to say we've had subsequently 638 YouTube views. So there may well be people who are managing to keep in touch with the business of the Council of Governors, albeit at a time that suits them after work, or they're free of childcare responsibilities or whatever. So I would suggest that we continue to make it available, despite what might appear like a low level of take-up. Kate has just raised her hand. Kate.
Yeah, thanks, Helen. On the issue of public attending these meetings, there are so many meetings now across so many fora that I think public will finish up being as busy as we are if we're not careful joining in on all these committee meetings, and I think perhaps they're getting a little bit meeting overload. So as you say, if there's anything they really want to listen to, they'll log in.
Exactly, and it's about the facility being available, isn't it? So,
yes, it is. Yeah.
Thanks for that, Kate. Very good, and thank you for the comments in the chat. It looks like people are content that we've had a good meeting. I'm very grateful to everyone who's contributed, and I look forward to seeing you on the 17th of November, if not before. But of course, we will come back to you before then, not least of all on the issue of how it is we arrange virtual or some sort of limited opportunity for governors to be involved in visits to the Trust. So thank you all very much, and enjoy the rest of your day.
Yeah, thank you.
Thank you, everyone.
Thank you.
Bye.
Bye.
Thank you.
Bye, thanks.
Bye.
Bye.
Bye all.